Good morning. I hope that you are very well this morning after the perfect networking dinner last night. Thank you once again for organizing such a nice dinner. And after such a dinner, we're starting to talk about the health issues and prevention of the health. And I hope that this morning we have a very nice discussion talking about sustainable health and disease management, the topics of great interest for our alliance, but for great interest for community in general. So five great experts in this topic will just present some results, and I hope that we will have a very fruitful discussion after that with the questions. Yesterday we see that the audience asking lots of questions, so hope this morning will be the same. If you not have the questions, I have few, so we can just continue with discussion. So order of presentations like a life, coming from the childhood to the old age, but we don't have the old age, but from the childhood to more technical details and more technical aspects of the health continuation and the issues. So first, it's my pleasure to introduce Professor Birute Strukčenskienė, Head of the Public Health Department at the Faculty of Health Sciences in Klaipėda University in Lithuania. And shortly, Professor Strukčenskienė is also Vice President of the Injury Prevention and Safety Promotion section at the European Association of Public Health. She is Professor of Medicine and Health Sciences and Medical Doctor specializing in pediatric trauma surgery. She has authored or co-authored more than 200 publications and 10 books and textbooks, and her research interests include injury prevention, safety promotion, stress management, health and well-being, healthy lifestyles, and the health and safety of children and young people. So please join me in welcoming Professor Birute Strukčenskienė and the first presentation this morning.
Dear moderator, rectors, vice rectors, heads, dear colleagues, it's a honor and pleasure to meet EU-CONEXUS community. And today I would like to introduce to you our study on child safety. Childhood injuries to society is very important, and preschool and primary school age is critical and important stage of child development, because in this period you can formate for him skills, abilities, and especially important, you can formate for child attitudes and approaches to health and safety. And recently, injuries is the first cause of death in children in Lithuania. So preventive initiatives and strategies in this age are very important to reduce mortality and ensure the safety in children. I would like to introduce one of our studies on where we aim to analyze attitudes of parents of preschool and primary school age children on injury prevention and safety promotion. The survey was performed not so long ago, and we investigated parents and caregivers of preschool and primary school children in Lithuania. We investigated parents and caregivers of children aged 1 to 10 years, so we could compare two groups, preschool and primary school children. The study revealed important results, that 75% of parents believe that accidental injuries have a significant impact on children. But what is very worrying, that only half of respondents, only half of parents know and believe that injuries are preventable, that we can prevent injuries. And parents, caregivers mentioned that most common type of injury in children was falls. And also, when they are wrong, they believe that main cause of death are diseases, not injuries, and that boys and girls are equally likely to get injured when participating in the same activity, what is as well wrong, because boys are nearly 3 times more often are injured than girls. So we see that parents and caregivers agree that they need to educate children about injury prevention and safety, but we need to educate themselves. However, only 1/3 of adults are very concerned about their children's accidental injuries, what is also big note for us, because it is only 1/3 of parents. We need to have then nearly all of them that they would be concerned about children's injuries. So, we concluded that parents do not have sufficient knowledge about childhood injuries and that more attention should be paid to their education about child safety promotion, and then more educational activities about child injuries, injury prevention, and safety promotion need to be organized for both parents and children. Thank you for your attention.
Working? Sorry. I'm not usually using these mics, so thank you. And the questions will be after all presentations, so thank you for this first presentation. Prepare your questions for later. There is lots of parents here. Some have some situations with the children injuries. Last week, I'm watching my colleague from Zadar, so maybe she will ask some questions. So thank you, very interesting presentation. So the second presentation, it's about health promotion and education and the focus on the Blue Health and One Health. So it's my pleasure to introduce Professor Ingrid Arnaudin, full professor at Biochemistry and Therapeutic Biotechnology at La Rochelle University in France. And Professor Arnaudin holds a PhD in biochemistry and is a senior scientist whose work focuses on developing bio-inspired solutions using molecules produced by natural resources, particularly in oncology and nutrition. She has published more than 95 scientific articles on the biological properties of oligosaccharides and peptides derived from algae, microalgae, and marine bacteria. In addition to her research, she is actively involved in European training initiatives and participates in numerous European and national research programs, including collaborations with industrial partners, and she is one of the great participants in EU-CONEXUS research network and research area. So please join me in welcoming Professor Ingrid, please. Thank you.
So thank you very much, dear colleagues, dear panelists. Good morning, everyone. So first of all, I would like to thank the host institution for inviting me in the panelists on this round table dedicated to sustainable health and disease management. Given the field of my scientific expertise, as you said, dealing with the valorization of natural substances from marine or coastline origin, valorization in health and particularly in the field of the breast cancer, and the thematic of this challenge, I decided today not to expose you part of my research, but rather to share an opinion or my opinion in order maybe to open a debate of what we can call blue health and one health, or blue one health. We can also fusion and merge these two concepts. So, as you know, 70% of our planet is covered by the ocean. And for decades, we have seen the ocean and coastline mainly as a resource. But today, science and our science remind us that the ocean and coastline it's much more than that. It's a living system that sustains all life and sustains our health. If we consider now marine biodiversity is not just an environmental issue, but it's also a health issue. And the two concepts, blue health and one health, show us now that the well-being of humans, animals, and ecosystems are deeply interconnected. In other words, if we protect marine life, we protect also our own life. So it's true that marine biodiversity supports human health. As you can see on this slide, I made the choice to mention 4 topics able to answer to this question, how marine life support us. First, as you can see, it acts as a natural regulator by filtering water, storing carbon, and controlling pathogens. Second, it brings us sustainable food. Coastal and marine resources provide us healthy proteins, essential omega-3 fatty acids, algae, and so on. And third, marine organisms could produce, and in the field of my expertise, marine organisms could produce anti-cancer, antiviral, and anti-inflammatory compounds, and don't forget that some of which are already used in modern treatments. So finally, let's not forget, it's for you, let's not forget the psychological and social dimension. Coastal environments have been proven to reduce stress, improve mental health, and enhance community well-being. Unfortunately, as you know also, you know that marine health declines, so does ours. Pollution by plastic, by chemicals, leads to contamination and habitat loss. Overfishing and habitat degradation also disrupt ecosystem balance. Concerning climate change, you well know also that climate change accelerates coral bleaching, for example, ocean acidification, and disease proliferation like zoonoses, for example. And each loss of biodiversity weakens resilience and natural protection, so affect also sustainable health. So the science conducted with our alliance, EU-CONEXUS, on all these subjects provided now us many knowledge. What we need, to my opinion, what we need now is more collaboration. We said that in a strategic workshop yesterday, and action. And with our different joint research institutes, for you, Ilinka, with the different joint research institutes, I believe now that it's possible to foster interdisciplinary research, connecting, for example, biology scientists, medicine scientists, medical scientists, and social scientists. And yeah, we take some example of what is possible to collaborate in order to answer to these societal challenges. We should, to my opinion, we should promote sustainable bioprospecting and ecosystem restoration. We need to integrate marine biodiversity now in public health strategy, and we have to protect our marine biodiversity because, like I said previously, it's also a way to invest in public health. So also in conclusion, when I have in mind the talk I want to give you this morning, when I'm thinking blue health, when I'm thinking One Health, when I'm thinking blue One Health, several ideas for scientific collaboration came to mind. To illustrate these two concepts, I want to focus on today in this panelist, in this round table. if in our alliance you want, for example, to conduct sustainable bioprospecting, it's maybe in your best interest to create a consortium of marine biologists and pharmacologists or biotechnologists, and we have this type of expertise in our joint research institute. So we are now to build a consortium in that way, if this field is of your interest. If, for example, another example, you intend to monitor marine zoonoses, maybe it's your best interest to associate ecologists for our GRI to epidemiologists in another GRI. And if you want to design blue spaces, for example, for mental health, it's a great preoccupation, and it's a national preoccupation for France this year. You may be associate psychologist with urban planners, and I think you have to find it in different joint research institutes. And another example, if you want to monitor evaluation of the health benefits of biodiversity, maybe it's your interest to associate economists with a coastal manager, and so on. It's 4 examples. And I believe that is by combining the different areas of our expertise in various joint research institutes that we'll be able to meet these challenges, the challenge of promoting health and managing disease, and of our coastal societies. So hoping that we'll be convinced now, and thank you for your attention.
Thank you. Thank you for one more interesting lecture this morning and presentation, and I think there are lots of questions here, and there is a lot of potential for cooperation, not more cooperation than questions after this one, and thank you for suggesting this cooperation and interdisciplinary research, which is the main hope of the main scope of this alliance and main scope of this research council, and even the conference rely on this interdisciplinarity. So the third lecture presentation is going to water pollution and environmental quality, and it's my pleasure to introduce Professor Jan Strenkner, Professor of Water Management at University of Rostock, Germany. And Professor Strenkner has a background in land improvement and environmental protection from the University of Rostock, where he also completed his doctoral dissertation on plant-wide modeling of wastewater treatment plants. Before joining academia, he was team leader in drinking water treatment and distribution in Dresden. His research focuses on interface between urban drainage system and receiving water bodies, process integrated industrial wastewater treatment, and the recovery of energy and nutrition from wastewater. He is also a member of the Leibniz Campus Prosperous Research and the Department of Maritime Systems at the University of Rostock. Please join me in welcoming Professor Jan Strenkner. Please, Jens. Okay.
Yeah, good morning. I'm also happy to be here and have the chance to present my ideas on water pollution and human health, or health more general. What you see here is the current assessment of water quality in Europe according to the Water Framework Directive, and you see in the orange bars is a not good state. So we see that in the surface water the chemical state is in most cases not good, and also the ecological state. If you're looking on groundwater, it looks a bit better, but still we also have here see that the chemical state is not always good, and also the quantitative state. What are the reasons? If we are looking on surface water, a lot of the pollution comes from atmospheric deposition, and this comes basically from burning fossil fuels, and a lot of this assessment comes from mercury. But if we are looking at where we can act, then you see also other diffuse pollution, namely agriculture, with 29%, but the point source solution, meaning wastewater treatment plants, is still available, but you see is in a lower priority. In groundwater, we see diffuse pollution, and a lot of this diffuse pollution comes from agriculture. And I will go on that. If you see the assessment over the states or the countries, you see the clear driver is, in most cases, population density. So where we have a lot of population, we have the worst conditions, and this is very often also related to industry. What you also see a bit is a mitigation in those countries where we have a high net water balance. So you can say somehow dilution can be some kind of solution, but of course not a real solution. But this is also biased by a heterogeneous assessment by the countries. Coming to agriculture. So I'm not the expert in agriculture, but agriculture is really a big driver impacting water quality, namely groundwater quality, and the two main issues are the excessive use of nutrients and also pesticides. But agriculture is also by far the highest net water consumer and contributes also a lot to water abstraction and affecting also the quantitative situation. In that sense, you could say agriculture is both victim and driver also of climate change. Nitrate is a big issue, and nitrate comes mostly from agriculture, so it has a direct toxicity. So the concentration, limit concentration of the World Health Organization is 50 milligram per liter. And no wonder exactly these 50 milligram per liter is also the limit concentration in groundwater according to the EU Water Framework Directive. And if you exceed this concentration, you cannot use the groundwater for drinking water purposes, at least not easily. But it also has indirect consequences because of its high redox potential. It mobilizes heavy metals, for instance. So nitrate reduction is really a big issue, but so far we haven't solved that problem yet. Phosphorus is also a nutrient, and what you see here on the photo is dead fish in the Baltic Sea. So it's very recent, so it's from October. The reason was or is also eutrophication of the Baltic Sea, and in that case it was then related oxygen depletion, and this is really a big issue. But on the same side, so we pollute our water with phosphorus, but phosphorus itself is a limited resource, much more limited than oil, let's say, because if it is empty, there's no replace. And at the moment we have only, so we have about 300 years left, but then our resources are empty. And this is a big issue also in water treatment, so we have to recover the phosphorus as much as possible. First, of course, we have to remove it, and then we have to recover it to bring it back into the cycle. So this is one of those things what we are doing. Another big issue, PFAS. We use it everywhere. I think some of you already used it today by using these cups drinking water, it is yes, everywhere used because it's water repellent, but it's a very tricky chemical. So it is persistent, so it cannot be degraded, and we even haven't found effective technical solution to degrade it technically. This is really a real issue, and it has also severe health problems. So it is related with liver damage and fertility problems, cancer, and so on. And at the moment, the only way to get rid of these PFAS would be to ban it. We tried it with several compounds of this PFAS family, but then industry implements another one with the same or more or less the same composition, so it's really a big issue. Last but not least, pharmaceuticals. We have more than I won't won't lie, but several thousand pharmaceuticals on the market, and we consume a lot. I will show in a later slide also the billions which we spend for it, and these are related with a lot of environmental problems. I don't read them all, but one I would also mention is antibiotic resistances. We discharge the antibiotics in concentrations which are low enough so that the bacteria do not die, but they can create their resistances, and we the main let's say pathway for pharmaceuticals and also antibiotics is wastewater treatment plant, and the wastewater treatment plant itself is a breeding cell for these resistances, so it's also a big issue. And this is interesting to see. If you see here on the left-hand side, there's no need to read the figures, but we spent billions of euro for these pharmaceuticals, and so our health insurance is very much that high because of this high consumption of pharmaceuticals. And what on the right-hand side, this is interesting to see, there's a links to education. So we are here in the blue bubble, so the lower part, we have good education, and in tendency, or statistically proved, the well-educated people consume much less pharmaceuticals than people who don't have this education. And there's a link between water, pollution, education, and health. And I cannot explain exactly what's going on there, but taking informed decision on pharmaceutical consumption is, of course, very important. And this is just one slide, what we are doing, what is my ecological niche in wastewater or in water treatment. We are dealing a lot with the dispersed point sources. So these sources which are in between diffuse agriculture and the large wastewater treatment plants, because we have thousands of these dispersed small point sources, and one is, for instance, stormwater effluents. This is the city of Rostock, 200,000 population equivalent, and we have all these black dots are stormwater effluents, yeah, and stormwater is not clean. On the middle hand side, you see our federal state, Mecklenburg-Vorpommern in north of Germany. These are all wastewater treatment plants, and it is a very rural area. And we have more than 500 wastewater treatment plants which are below the threshold where they need to remove nutrients or even a fourth treatment step for micropollutants. So how to deal with all these small wastewater treatment plants. And on the right-hand side, specific topic is the runoff from agriculture farms. This is heavily polluted. So if you measure the stormwater runoff from some farms, it is is even more polluted than raw wastewater from an urban society. No one cares for it so far, but we need treatment there. And this is also related with hygienic problems, of course. So this is what we are doing in Rostock very often, or mainly. I would like to summarize. What I've not told you is the problem of the oral fecal cycle, because we resolved that problem in Europe. Every 30 seconds, one child is dying from waterborne diseases. Every 30 seconds, but not in Europe. We have solved that problem by an effective drinking water supply and sanitation, but this needs to be maintained on that level, and this costs a lot of effort. But we have to do much more on proactive mitigation of pollution. I named nitrate, phosphorus, and micropollutants. And then in that priority, we have to think about how to implement technical barriers to ensure our water and food quality. And only in the last priority, we probably also have to think about of a posteriori rehabilitation measures. Thank you.
Thank you. Thank you. Lots of interesting information, and I hope that will produce more discussion after this, because I see lots of interesting data. So after me coming to more, I will talk about more details about data management, and my great pleasure to introduce Dr. Maria Eugenia Gas-Lopez, coordinator of the Big Data, Artificial Intelligence and Biostatics area at La Health Research Institute in Valencia, Spain. Dr. Gas-Lopez holds a PhD in genetics from the University of Valencia and has more than 20 years of experience in molecular biology and biochemistry. She has worked as a researcher at the Barcelona Biomedical Research Park in the Principe Felipe Research Center, focusing on the gene expression, regulation, and renal metabolism science. 2019, she has contributed to more than 20 e-health and health data science projects, bridging the public and private sectors with translational approach. She has participated in a number of the projects and currently coordinates the Omics Space, a flagship initiative on federated health data. In addition, she has taught at master's programs in precision medicine and biomedicine. Please join in welcoming Dr. Maria Eugenia Gas-Lopez and talk from data to sustainable health. Please.
Thank you. I would like to start by thanking the organizers for giving me the opportunity to present the work we are doing and be involved in this roundtable. And as we said, I would like to explain you the work that we are doing in terms of interoperability research ecosystems. Okay. I would like to start by explain you why some of the challenges that healthcare systems are facing currently. First of all, one of these challenges is the aging population, that this drives to a growing demand for care resources. And also we have a problem with that this leads to an increase of chronic diseases that at the end it turns that we need for long-term and coordinated care. We also have fragmented care. That means that, I don't know, probably you always have heard that maybe you go to primary care and after you go to the hospital and you complain because they are not coordinated. This means fragmented care. Also, we have limited interoperability. This has the consequence that they have data silos, and this leads to inefficiency because we are not able to connect all the information. And there is also a pressure to improve outcomes while controlling costs. And in this transformation, one of the things that might help to get a more sustainable system is what is digital transformation, in which analyze the data has a real impact. That means that this challenge that I explained you before requires a shift in how we manage health systems toward a system that is more integrated, data-driven, and patient-centered model. In this slide, what I want to summarize is like what means when we are talking about digitalization. Digitalization is something more than technology. This means that we have to put the data and patient at the center, and the digitalization process gives us the opportunity to turn data into a strategic asset. And why this is? Because if we think in patient-centered care, we don't only think about what is included in the electronic healthcare records. We need to know that we have to integrate, that there is more data that we need to manage. If we have all this process, we have to provide to physicians with tools that will allow them to have an easy access to clinical relevant information. And the system that we are providing, they need to integrate clinical knowledge and also best practices. Also, if we want to have a continuity care pathway, we need to promote multidisciplinary teams. They need to be collaborating. And as I said before, we need to integrate data from different sources. And this will allow us to take decisions based on evidence. And also to implement, it's not that we only can implement what is called 5P medicine, but also value-based healthcare. Now I would like to explain you the digital transformation process that we are doing at Lafayette Health Research. Well, it's Lafayette Health Research Institute, but we are collaborating for sure with the Lafayette Hospital Lafayette. And I wanted to start explaining you that the community, the Valencia community region have 24 healthcare areas. One of these healthcare areas is Lafayette Health Department. And here, what I indicate is the current data environment that we have. In this green part, what is represented is the corporate health system. That means that I go to the hospital and they run a lab test. It will be stored information in one of these corporate systems, okay? From this corporate system, the IT department, the hospital IT department has prepared different views, okay? This makes that this data can be accessible and we can analyze this data. The blue environment is what we call production environment and can be only accessed for primary use. That means for clinical decision. If you check the data that is stored there, you can see names, for instance, okay? The blue one has an identical copy, is the second one. And this is the test environment. It's identical, as you can see in the structure. And the idea is that before moving something to the production environment, it will be tested in the second one. But you see that there is a third one that is depicted in orange. This is what we call big data platform. And this environment is only intended for secondary use. That means for research purposes. And the difference with the others is that in this case, the data is pseudonymized. That means that if we check, we cannot see the name of the patient, okay? But here, all these things that I indicated with this, well, this or this or this is what we call local format. That means that imagine that we write down everything in our own language that no one can understand. That means that we can have access to this data, we can analyze this data, but the conclusion that we will draw or everything that we will develop, it will work only in our environment because this is our own special language that no one can understand. But as you know, if we want to collaborate in a research project, we need to be able to exchange and collaborate and work together. And how we can resolve this? We can standardize this database that is, as I say, in a local format, and we standardize this information in one common data model. That means that imagine that we translate all the information that we have in our own special language in English. That means that we allow us to collaborate because now we can exchange the information. And because the three environment that I can show you here are identical, that means that we do something in the context of a research project. That means that we are working with the orange one. We can translate what we have done to the other environments for primary use. If I have to, well, in this case, we have access. If we are talking about the patients that we are responsible for, that is around 300,000 patients, we have information from primary to tertiary care. But the 60% of the activity of the Lafayette Hospital is due to the reference activity. In this case, we can only see what is happening inside the hospital. And we have to give you some numbers. I can tell you, well, this database is updated on a daily basis. And the pseudonymization process is controlled by the hospital IT department. And I can give you some numbers. Well, currently we have information for 2.8 million citizens. And you have here the numbers of the data marks and the table that we have, the columns and the rows. But the rows is increasing because every day the database is updated. That means that if something is going on, for instance, today at the hospital, they are running some lab tests. Tomorrow morning, this information will be in the platform. And there is also 40 million nodes, 40 million of clinical nodes. And sorry, no, it's in the other way. No.
Okay.
Oh, shit. Okay. Like this. Here. And the information that we have, if I have to summarize, currently in this orange environment, because the big data platform, currently we don't have access to omic data. We don't have information that is provided by the patients. That means we don't have prompts, sprints, or we don't have information that is collected using devices. And we don't have, for instance, information for the biobank. And now, this year, well, at the end of the last, in 2024 we got a funding from the Spanish ministry, and we are running one project that is called Omic Space. And this project aims to prepare and build up a federated data space for healthcare research. In this case, what we are doing is that we are incorporating more information to the one that I previously described. We are integrating genomic data and information from the biobank, and also we are preparing and connecting a federated network. That means that we already have connection with 7 other nodes that are places in different parts of Spain, and also we are connecting with one European database that was made in the context of 2 European projects that were called Harmony and Harmony Plus. That means that in order to do this, we have to speak the same language, and that means that we have to work with standards, and we have to be connected. And it's something that we are doing right now. And why we are doing all this, or what do we need if we want to do all this? In order to do this digital transformation process, what we have done is we need to have a cultural change, and we also have to change the structure of the organization. It involves or implies that we need to have more digital skills. We have to have interconnected and interoperable system, and we have to have a good data management. If we do all this, and why we are doing this is because if you are doing this digital transformation process, you can increase collaboration between structures and citizens. You can transform data in key information. For sure, you can boost translation research. You can improve decision making. We can move to what is called 5P medicine, and also value-based medicine. That means that you are not only checking outcomes, you are measuring what you are doing, and you can also do benchmarking. You can compare with other institutions. And I wanted here only to summarize that all the key benefits that we are doing, for instance, for the digital transformation of one project as Omic Space, this has an impact for sure for the research and for the industry, because, as I say, it's an ecosystem, an innovative ecosystem that promotes the collaboration between private and public organizations. It promotes the capacity to do translational research, also have an impact on healthcare professionals, because, as I said before, the idea is that they can have access to more information, more connected information, and they can have tools that they allow them to take decisions, and we can give tools for them to make decisions that are more evidence-based, but also have an impact in patients and society. And for the last, I want to explain and to say the idea that what we are doing at La Fe Health Research Department is we are putting patient and data in the center. We know that we have to interconnect with other institutions and also interconnect data if we want to move forward, and that all this has done, you need to integrate data from different sources, and this might have always an impact. Or everything you have done, you have always to keep in mind that the idea at the end of the day is that you have to, what you are doing might have has to have an impact on patients and citizens and society. And that's all.
Thank you. Very interesting to understand digital transformation, digitalization, differences between these two, and the benefits of the good data. Thank you, and we are coming to the fifth presentation. It's my pleasure also to introduce Dr. Sofia Mavricu, Assistant Professor at the Laboratory of Cell Technology at the Department of Biotechnology, School of Applied Biology and Biotechnology, Agricultural University of Athens, Greece. Dr. Mavricu holds a PhD in the development of bioelectric, biosensors, and vitro toxicology, MSc in natural products and enzyme technology, and BSc in biotechnology, all from Agricultural University of Athens. Her research focuses on the development of biosensors, in vitro toxicology, cell and tissue culture, and biochemistry. She has participated in numerous national, international research projects and has authored and co-authored several scientific papers, book chapters, newsletters and conference publications. He's also the editor of an international book, holder of national patent, and co-founder of the AUA spin at University of Athens spin-off company, pioneer of diagnostic technology, and she's a recipient of the Idea Incubator Competition Prize and the Innovation Award from the Greek Ministry of Defense. So please join me to welcoming Dr. Sofia Mavrikou and her presentation.
Thank you very much for inviting me to be here today. As already said, I'm an assistant professor at the Department of Biotechnology at the Agricultural University of Athens, and my expertise is in the development of biosensors for several applications. So my today's presentation is going to be a little bit broad, covering the part of early warning and the detection of diseases, and specifically zoonotic diseases. So we already have the previous paradigms from the pandemic of COVID-19, and also from diseases such as SARS, MERS, Ebola in Africa. And all these lessons have taught us that we have to be prepared for diseases that are going to occur from animals, zoonotic diseases. So, zoonotic diseases basically make up about 3/4, as you can see in the slide, of the infectious diseases, posing global health, economic and environmental challenges. So the outbreaks of COVID-19 and Ebola have cost billions in losses of deaths, human lives, livestock, and basically many economical losses, and increase the link between the infections from animals to humans. All these diseases lead to ecosystem disruption, and basically they occur from the effects of climate change that we already have noticed all these years. So what we need is to have an One Health approach in order to be prepared for the cases of emerging new diseases that are going to arise through the climate change effects. And basically we need early detection systems and robust surveillance systems to prevent future epidemics and pandemics. Modern technologies are basically helping us to have disease surveillance from slow manual to real-time and predictive platforms. So instead of mainly relying on laboratory reports, we now integrate data from the public health, from the environment, from animals, and from digital sources. So we have, as you can see, 6 main technologies. We have big data analytics, artificial intelligence and machine learning, the IoT, Internet of Things, geographical information systems and spatial analysis, remote sensing, and diagnostic technologies, molecular technologies, and point-of-care technologies. Each of them plays a specific role, from collecting data to analyzing patterns to predicting outbreaks before they spread, and together they form an integrated system capable of turning complex data into actionable insights. So I'm going to start from big data. Even the previous speaker have covered a lot of what I wanted to say regarding this part. We already know that big data can process vast, diverse data sets, including health records, lab results, even social media. And IoT, the other technology, is ordered to identify any early warning signs. For example, in China, we have the integrated health big data platform that was able to detect additional dengue and tuberculosis cases that were missed by manual screening. On the other hand, we have the multi-omic approaches that are combining genomics, proteomics, and metabolomic data in order to trace transmission and identify several vaccine targets. Artificial intelligence builds on this by recognizing patterns and forecasting outbreaks. An example is the Blue Dot application that you can see at the slide. The Blue Dot's AI is supposed to be the application that was able to flag COVID-19 outbreak by scanning global news and articles days before the official alerts occur. So, additionally, we have machine learning that are models that have also predicted some examples of dengue fever outbreaks by analyzing weather and vector data. We have some online signals like spikes in search terms for avian influenza that have been preceded lab-confirmed outbreaks, and together these tools move us from reactive response to proactive prediction, though we have some issues like data quality, privacy, and bias that still need attention. On the other hand, we have the IoT technology, the Internet of Things, that connects several networks of different sensors and devices that can continuously monitor humans, animals, and environmental parameters. We have some wearable sensors that can track livestock health. This could alert authorities when abnormalities appear, and in this way we could prevent a wider spread. During, as an example, during an Ebola outbreak, IoT devices helped remotely monitor patients' vital signs, protecting healthcare in healthcare workers. The geographic information systems add the spatial layer by mapping hotspots, by tracking disease movement, and identifying high-risk zones. An example for GIS mapping was a case in Iran in 2014 that could monitor the hotspots for leishmaniasis and brucellosis and helped authorities target not only vector control but also vaccination programs. And by combining IoT's real-time monitor with GIS spatial analysis, we could visualize and respond to disease threats more efficiently. We have also remote sensing and satellite imagery that takes surveillance even further by basically observing environmental changes that can influence disease spread. Using drones or even satellites, we could track parameters such as the rainfall, the vegetation, the temperature. All these are factors that affect vector populations. So, a case in Italy, some researchers combined satellite imaging with deep learning in also to predict West Nile virus activity that was based on soil moisture and temperature data. And on the other hand, as you can see, we have the well-known model of NASA, the USDA's Rift Valley Fever Early Warning System, which is able to monitor vegetation and sea surface temperature data to predict some outbreaks months before in advance. So all these tools allow governments to act preventively, for example, by vaccinating livestock or launching mosquito control before outbreaks occur. And we also have the diagnostic technologies, molecular and point-of-care technologies. At the laboratory field, we have molecular technologies for precision detection of several pathogens. We have the gold standard, the PCR technique that identifies infectious agents very quickly and helps with the help of next-generation sequencing that allows complete genome analysis and is essential during COVID-19 to track several variants and transmission routes. A relatively new technique is the LAMP technique, a very rapid and portable method, ideal for field use in resource-limited areas. Meanwhile, we have, as a previous speaker said before, the environmental and wastewater surveillance that detects hidden circulation of pathogens like, let's say, Leptospira or other enteric viruses, providing early warning of community transmission. And finally, we have portable techniques such as biosensors and connected point-of-care devices that enable us now for real-time pathogen detection, even outside the laboratory. These tools can bring diagnostic technologies closer to the source, reducing any delays that occur from extensive sample pretreatment or laboratory techniques and improving the response speed. So we have, beyond surveillance, these technologies can also improve the response during all these outbreaks, the zoonotic diseases outbreaks. Early warning systems analyze data continuously in order to flag the abnormal signals. For example, let's say we have some systems that can detect changes in the poultry vocalization and can identify the avian influenza days before the pandemic in the flood. Information sharing platforms link public health, veterinary, and community data to promote rapid coordination. Basically, during the COVID-19 pandemic, the CDC's digital communication platforms helped countering misinformation and guide public behavior. And point-of-care diagnostics, such as the Abbott's ID Now test, provided results in less than 5 minutes time, enabling quick isolation and treatment. Telemedicine is another opportunity for remote diagnosis and treatment, especially for patients in quarantine or remote regions. There are some apps like the Trace Together system and Radar COVID that have been used and doubled the number of the detecting contracts compared to manual tracing. And together, all these innovations shorten the time between detection, communication, and intervention, a very critical factor for saving lives. So, despite these advances, there are several challenges, implementation challenges, we could say, that remain in order to have some effective early detection systems. We have many low-income regions that still lack the infrastructure and connectivity needed for real-time surveillance. We have the problem for data privacy, interoperability, and political barriers that continue to limit information sharing. And you know that predicting zoonosis, those that are not yet identified, requires integrated systems that are capable of detecting anomalies across all these pillars, across human, animal, and environmental data. So achieving a truly global system will demand stronger One Health collaboration stronger policy alignment and sustained investment. To move forward, we must expand digital infrastructure, of course, train the personnel, improve data governance, and build public-private partnerships to mobilize expertise and funding. So, in conclusion, integrating technologies such as artificial intelligence, IoT, and diagnostics allow us to build faster, smarter, and more connected surveillance systems. By doing so, we can move from reacting to outbreaks to predicting and preventing all this days before they occur. So, thank you for your attention.
Thank you, Sophie. Thank you to all presenters. It was very interesting listening to your opinions about health prevention and health management. And I hope there is a lot of questions now, and they are very happy to answer to all your questions. So see the smiles on their faces, like waiting for your questions. So I'm just opening here for questions. I hope there is a question. There is a very interesting for the future. So, okay, if you don't have a question, I will start. Oh, thank you.
So I would like to ask a question for Maria Eugenia related to the database and all. Are risk factors being considered, like for example, I know that for hair stroke, which is kind of a rising concern sometimes in healthcare because it has a lot of like, well, lots of cases have been reported, of course, like it's a common disease, let's say, or a common happening in society. Some risk factors are like sometimes like something to be expected, like for example, people have some weight issues or people having like some lifestyle, more like lifestyle related, but also being able to be recorded in like the medical records, sorry, like also smoking. But also I once saw an article that saw that there was a statistically significant difference between, for example, their fields of work. People who were working in more like a stressful fields of work were undergoing or were under bigger risk of suffering of hair strokes, and I think that's also can happen with other kinds of diseases that are kind of common inside society. So my question basically is, what kind of like factors of risk are being considered in the database, if any, and also if you think that implementing this database and trying to go for a more personalized healthcare for people would also mean that we have to maybe rethink how primary care is given and what questions are being asked to the patient in first instance.
Okay, related to the, if I understood you, the first question, I guess that you are asking me if during our research we have identified some.
Do you consider like any kind of risk factors, for example? So because I think it's not like it was like global, right? Like they're considering lots of factors and lots of like maybe potential diseases. So for instance, like how do you think for risk factors and what are you considering now?
But I have to tell you, because I guess that if you ask me about specific diseases, I will tell you the risk factor that is not, because when you read and already when you speak a doctor, they will tell you. Yeah. But I guess that you are asking me if we're using and analyzing the electronic healthcare records, the real world data that we have. Yeah. I have to be honest, because when we are running some different projects, all the questions they are doing, and it's related, how we say, depending on the work, the people, we don't have in general. I'm talking about globally, in the population level, we don't have all this information of lifestyle. Then we have this limitation. When we are doing different projects, in general, what's happened, for instance, we were running a project that was focused on lung cancer. Then the physician asked us if we could identify or measure different KPIs. And what's happened sometimes in general, all these questions that you are raising, they have a lot of relevance. But when we start to analyze the data that we have collected in a retrospective way, we cannot give a good answer, a good analysis. And what we are doing in all these projects in general will always happen independently of the disease that we are dealing with. At the end, what they identify, they realize that they need to have all this information, and they arrive to a compromise. That means that we have, because we always work, for instance, in the lung cancer project with multidisciplinary team, and we sit on the same table, all the professionals that are involved since the first moment that the patients have contact with the healthcare system, and they say, okay, we realize that we are missing this information that it was really important. They identify, imagine 50 the variables that are relevant, but they know that we're starting to implement improvement of the medical record, the registry, because we only will have a really good databases for secondary use if we have a really good databases for primary use. Yeah. And what's happening is that they arrive at a compromise. They say, okay, we have to be realistic. We cannot improve, and started to collating, the 100 variables that we want, but we're starting compromising, collating this one, and maybe it's only 10. And for instance, in lung cancer is what we are doing, because they are also, in lung cancer it's true that we can have the smoking habits, okay, but it's not always completely and well record in the electronic healthcare record, because all this information in general is registered in clinical notes. And the way that they collect is different between professional and the other. And for instance, in this case, they decide, okay, we know that this is relevant, the habit, or the other, if the alcoholic habit, and they have arrived to the compromise that from this day we are going to collect this variable systematically in this way, and then it will be easier for us, and we can run all this. And sorry, I forgot the second question that you asked.
It was more related to because now it also has to do with this fragmented healthcare system that we have sometimes, because something I find kind of curious is that, for example, in my line of work, well, because I'm working as a researcher in this university, so we have to undergo, for example, under a mandatory healthcare check. But it's curious because then I think those reports, can they be accessed, for example, by the hospital, by the another healthcare systems, or is just limited for the company that's dealing with this kind of check?
You're talking about the access that we have for
for example, because if there are records of people, because in this case, for example, you ask if you smoke, or for example, alcohol consumption habits or things like that. Can those records, for example, be accessed by the hospital to for example, work on your research, or considering all these risk factors, or since it's another institution, it's just separated?
In our case, because all the information is in the same institution, we can have access. When we have to give access to, well, it's not easy that we grant access to another institution, okay? We have to go for a process because there is a data governance model. But if it's inside, we can have access, but it's to always have a procedure. It's not that I want to have access to the data because I'm running a research question. You have a procedure, you have to demonstrate, you have to justify, and there's a procedure, and you fulfill everything that is required, you can have access. But always there are different, at least in Spain, that you know that you have different legal basis to have access, and you have to fit in one of the, in your case, it's I don't know how to say in English, but I don't know how to translate the law in English, sorry, but disposición adicional decimoséptima, if someone can translate this, but in this case is how we can have access to this information, okay? So.
Thank you.
Thank you.
Thank you. More questions? I know.
Yeah, thank you. Thank you very much for all your presentations. It was really interesting to hear it. I have actually a question for Professor Birute from the Klaipėda University related to children injuries. What are the main causes of those injuries in your country and maybe in some other European countries? What are experiences? And why I'm asking, because in Croatia, where I come from recently, we have a huge increase in child or children injuries related to the scooters, particularly these electric ones. I think in Croatia last year only it was more than 200% the increase of injuries among children related to this problem. So I consider it a problem. So what are the experiences in other countries? As a surgeon, I see you're a surgeon, so do you have similar problems and how to deal with this?
Thank you for your question. Yes, if you talk about Lithuania, so half of injuries, fatal injuries in children are road traffic injuries. The most serious with most bad consequences, with disabilities and long-term consequences. As well, generally in child injuries, in Europe we know about 5 main causes of injuries, so it's road traffic injury, burns, drownings, falls, poisonings. And regarding road traffic safety, yes, scooters recently are a big problem in many countries. There was very popular new mean of transportation for kids and for adolescents and for young people. But some countries now already started to give restrictions for using scooters because we are not prepared for them really, and we don't have enough measures for scooters. We have very terrible tragedies in Lithuania when children died in accidents when they were riding scooters. One child, for example, died when parents have seen this situation, and after that traffic police used more measures like controlling on the streets if child is riding with helmet, if he has vest, if he stops beside traffic lights, and if he goes by foot through traffic light, not driving scooter. And generally now we need to think about more active measures what we could use for these scooters. So maybe that, thank you.
Thank you. More questions?
I have a question.
Okay. Please.
Yeah, I have a question to Sophie Mafricou concerning this sampling. I understood very well that you monitor the drivers, but how about the sampling to get the real information if they are a pathogen, yes or no? What do you sample? Do you sample water? Do you sample insects or whatever?
It depends.
It depends.
Regarding the application,
Yeah.
we have developed sensors for blood plasma, for rhinopharyngeal swabs during the COVID period. We also developed sensors for water monitoring, so we could have water as a sample. And of course for food safety applications, because the diseases could also be spread through the food chain. So it depends regarding the sample.
So as water engineer, I was thinking about if there exists already, let's say, online sensors in water which work completely automatically, or is it always, let's say, handwork? And then if it is always handwork, how comes this Internet of Things into play? Because if you do handwork, then you can also put it in as number.
Well, there is a trend that we need water monitoring without any external interventions during the sampling, but to my knowledge, I don't think that there is something an already available solution for this yet. But
Okay, thank you.
Thank you. More questions from the audience? No? I have the question for the Ingrid. When we discussing before this one, and to what extent can the principles of the Blue Health and One Health be integrated, let's say, in a national and EU public health frameworks to promote long-term ecological and human well-being? Something like that. What is your opinion? What is the future of this?
I don't know. Just say that it's already done, because One Health, for example, is a concept already established in Europe, EU policy. So we can revendicate it, and we can apply more and more research in that concept. Concerning Blue Health, you have also an Euro